I wanted to I've been very sick since 2010 was when I was diagnosed with chronic pancreatitis. And I'd wanted my pancreas out for a number of years, but I was told that no one could perform the operation. So then when I was admitted to the hospital in 2016, after 2 times of being admitted, I was in for a very long time. And so I searched by myself and found Dr. Gruessner in Syracuse on Google, and I made an appointment for him. My mom had made appointments with other hospitals like Boston and one in Maryland, I believe. But I made the appointment with Dr. Gruessner at the end of August 2016. And we went and saw him, and I had like complete confidence. I told my mom to stop, like cancel all the other appointments that she had made because I knew that he would be able to help me. I cried the first time I saw him. So
I remember Catherine because she was driving about 200 miles to see me from Buffalo to Syracuse, and her medical history, unfortunately, is not unusual for a patient with chronic pancreatitis, which is a very debilitating, crippling, progressive, and irreversible disease.
we had looked for someone who had experience doing just a total pancreatectomy, and we had found the total pancreatectomy auto-islet cell transplant that we thought that I would be a candidate for. And I knew that he had a lot of experience through Minnesota and Arizona, and that his experience was good. And then when we met with him, he had explained to my mom that he had done many of these surgeries and that he had a great track record. So I really wanted someone who knew what they were doing and could handle my altered anatomy, because not a lot of people know how to handle someone who's had surgically altered anatomy in their stomach. And I also wanted someone who wasn't just trying to push their program, because there's a lot of other places that don't have, like they just have a new program coming out, like South Carolina, I feel like, is one of them that just keeps finding people to grab. Like, oh, you have pancreatitis, let me operate on you. And it seems like from my groups that seems to be happening in a lot of places that don't have they're just trying to start their programs. And I have met a lot of people who don't necessarily seem like they need the surgery. They don't have all the symptoms that would mitigate needing a surgery like this. And they're being told that they qualify for a surgery that is life-changing, and there's other options out there for you. So he wasn't forceful, and that made me feel very good. It was, we're going to take this slowly, and I don't want to do this before we have everything we need for you. I don't want to jump into this, and that having that caution is very important.
Well, I think there was agreement that the pancreas had caused so much medical troubles in her life that it had to be removed. And usually surgeons shy away from doing a total pancreatectomy because it renders a patient a diabetic, more so than a type 1 diabetic, because not only the insulin-producing cells, but all of the hormones that the pancreas produces are being removed. So surgeons usually are very shy about recommending a total pancreatectomy. There are several centers in the country that offer the removal of the pancreas along with a simultaneous islet transplant, where you take the insulin-producing cells of the diseased pancreas, you isolate them, and then you give them back in the same procedure the following day, either surgically or by interventional radiology means. For Catherine, unfortunately, that was not an option because she had developed type 1-like antibodies, diabetes type 1-like antibodies, that had already caused a toll on her, and that she required some insulin even before we were talking about the total pancreatectomy, and that got worse over time. So using her own islets was not an option. We are, of course, here at Downstate committed to building a chronic pancreatitis program where islet transplants are being offered. But there are about 1/3 of the patients that are already diabetic. And chronic pancreatitis goes along with chronic pain syndrome. And that is really why the pancreas needs to be removed. If the intractable pain that people that are not familiar with the disease don't understand, patients, normal patients like Catherine, working full-time, depend suddenly on narcotics, on opioids, just to control the pain. And it's a spiral that is almost impossible to get out. Now, the interesting thing, for example, is after we did the surgery, Catherine required a lot of pain medication. But as the wound pain went away, and the pancreas pain obviously was gone because the bad organ was removed, she required less and less pain medication. And I'm almost sure that within the next 3-4 months, she will require very little, if any, pain medications and will continue enjoying a normal lifestyle, getting back into her profession and doing what all people of her age do. I mean, work and enjoy life. And I think that's what this procedure can do. Now, for Catherine and for patients in whom islet transplantation of the native pancreas is not an option, if the diabetes gets so bad that it really causes side effects, and obviously a diabetes can do that, then there's the option of doing a pancreas transplant. And if we do a pancreas transplant, not only would the diabetes go away, but that newly transplanted pancreas would secrete the enzymes to digest the food again. It will allow her basically to have a completely normal lifestyle, with the exception that she would have to take medications that avoid the occurrence of rejection of a transplant. So we shall see how all this moves forward as Catherine is now heading back home. And if her diabetes is controlled, a pancreas transplant would not be an option for her because she's doing fine otherwise. If, however, the diabetes acts up in years to come, then a pancreas transplant might be an option for her to replace the function that she has lost, that is the endocrine function for diabetes and what we call the exocrine function. Those are the enzymes that digest the food.
Oh, I'm still it's the first time that he told me that I would be able to experience no pain. I didn't know what that would be like, and it was sort of unfathomable to me because I've had so much pain for so long, and it's a pain that I never, no one ever could understand. You know, you tell people I'm in pain, and they expect you to just, well, suck it up. You can still come out and do things with us. You can still hang out. You can still work. You can still carry on a normal life as long as you take, you know, a medication. And medications still, they are okay. They don't take away the pain that you experience with chronic pancreatitis. It is by far the worst and most severe pain that I think that I have ever been through, and I've been through a lot of pain. So I couldn't believe that after surgery, I didn't hurt as much as I did when I was in the worst flare of my life. And I had just had my stomach opened up and had an organ removed, and it hurt less. And that was something that I didn't know that I could believe that would happen when I first talked to him, but it did. It worked. And I'm in less pain now than I was prior to coming in, which is amazing to me because I'm not even 2 weeks out of surgery. So it's so exciting to be able, I can actually I never doubted that I would get my life back, but it's one of those things that you, after having so many falls, it's like, well, I believe this person, but I have to still wait and see. You sort of hold that a little bit back, that belief. But now I can actually look forward to it. And I'm super excited. I can't wait. I can't wait to get life back.
You had mentioned that that some surgeons had been reluctant to take on your case.
Yes.
But that Dr. Gruessner was quite different by contrast.
Yeah.
If you could explain.
I've had surgeons just not call back. We've called several times, and they would tell me that I was too complicated for them. Or I would meet with them, and they would tell me things, straight lies, like, we can't help you. There's no possible way that we can there's nothing for you. And Dr. Gruessner was completely opposite. He sat down with me, and there was no hesitation on his part to take on my case. The first time I met him, he said that he could help me, and he did. And that's a big difference from almost every surgeon I've ever seen, except for one other surgeon. And it's amazing when you meet a doctor who is willing to take you on. I think that the teamwork here is something that sets apart Downstate from other hospitals, because when you don't have to worry about your teams communicating with each other, it's less stress on you. When you're worried about teams communicating in other hospitals, them not giving the right information or receiving the right information, it does put stress on you, because then you don't know what each doctor is going to do when they come in, such as having your meds changed 4 times in a day, which has happened in past hospitalizations. Here, there's one person in charge. There's one team in charge. And when there is multiple teams that were coming into my room every day, but they were all on the same page, which was fantastic. So I told them that when I was in my room, I was like, I can rely on you guys to talk to each other, and that's great. And there was teams coming in together, and they would talk to each other when they were in the room, which was even better.
Well, I think we want to build an exemplary program here at Downstate. There is really no dedicated center in all of New York City taking on complex and complicated patients with chronic pancreatitis. Frequently, patients with chronic pancreatitis are labeled as alcoholics, because one of the reasons for chronic pancreatitis is alcohol abuse. But that's true for maybe 50% of all cases with chronic pancreatitis. And then there are others, like in case of Catherine, where we poorly understand the etiology of the disease. But there are genetic, there are hereditary reasons. There's autoimmune chronic pancreatitis. There are many reasons to develop it. There are thousands and thousands of patients out there with chronic pancreatitis, and many of them do not get the proper care because, as I mentioned before, surgeons are reluctant removing the entire pancreas, and most academic centers and big hospitals in the country do not offer islet auto-transplantation at the same time. What the procedure does in the end is it gives the patient their life back, because many of these lives are broken because patients are losing their jobs over it. They are called opioid abusers. They're not taken serious, sometimes not even by their own families or loved ones. Marriages have failed as a result of that. The question always being, is it really that bad, what he or she says? Well, I mean, it is that bad. And when you look at the transformation that this organ goes through as part of the chronic pancreatitis process, you have an organ that has the consistency of a salmon fillet and is pink in color, and eventually becomes rock hard, gray and whitish, and sits right in the middle of the body, attached to your stomach, to your colon, to your small bowel. You have the blood vessels there, you have lymph nodes, you have nerves. That's the reason why the pancreas is one of the most treacherous organs of all. Chronic pancreatitis is also a precursor for pancreatic cancer, which is probably the deadliest of all solid organ cancer that we know. So it is an organ that has been vastly underestimated in all the negatives that it can do to a person. Even for patients with type 1 diabetes, insulin is not a final solution or a cure. And then in case of destruction of the tissue that produces the enzymes, it can cause some horrific pain. And I think that's what most patients are going through. The pancreas does the following. There are two parts. One is called the endocrine pancreas, the other one is called the exocrine pancreas. The exocrine pancreas, produces hormones that are secreted into the bowel and digest the food. 98% of the pancreas are cells that are in the business of digesting food. 2% of the cells, and they're not connected to the other cells. 2% of the cells, and they have their own blood circulation, produce hormones like insulin, which lowers blood sugar levels, or glucagon, which raises blood sugar levels. And then there are another 3 or 4 hormones that the pancreas is producing. The endocrine portion of the pancreas accounts for only 2% of the mass of the organ. And it's very difficult to isolate these cells because they don't have red flags on them. They're difficult to isolate and to give back. So even in experienced hands, when we do what we call an islet isolation, about 50% of those cells are lost just by the isolation process itself. But it's a very treacherous organ. It was not described until the 3rd century before Christ. It took another 400 years until the name was given, and it took another 1100 years before we had the first description in the Western world. The first total pancreatectomy was not done until the 20th century. That tells you, I mean, how tricky things are. And the dual nature of the pancreas with an exocrine and endocrine portion was not fully understood until the end of the 19th century, when surgeons took out the pancreas and realized that an animal, in that particular case a dog, would become diabetic. So no one had really an idea about the interaction of the pancreas with diabetes one side and digestion on the other side.
I'm not sure what the pathology is shown, but we were thinking, because I would get a flare of pancreatitis, severe pancreatitis, to put me in the hospital every time I was sick, or I had gone through some sort of a surgical procedure, anytime there's stress on my body. And the last major bout that cost me my job and everything was after a viral bronchitis that had lasted for a month and a half. And then I was sick constantly. Yes, well, I have to recover, obviously, and get my strength back. And then I'm getting my license, because I have my master's degree in social work. So I have my plans to get my license and then go back into social work. So I'm excited. I'm just so thankful. I'm so thankful.
Well, I just wish Catherine that now that she has her life back, she can plan again without having to go to the hospital on a regular basis, without asking physicians for medications that label her as a drug addict, and all the negative connotation that came with that disease. Being back to a normal life, despite the fact that she will be diabetic, is in the end probably a smaller price to pay than continuing with this terrible disease.